further ado, I welcome our two guests, Mona Abdullah Hijazi. I'll just read out her bio. As a community engagement manager at Access, she leads the Access Substance Abuse Program, Community Coalition, and works with Syrian refugees and the Building Blocks for New Americans programs. She's currently a member of Healthy Dearborn Coalition Steering Committee, Greater Detroit Area Health Council Opioid Task Force, the Michigan Department of Health and Human Service Prescription Drug Overdose Prevention Team, CADCA member, Michigan Open Advisory Board, Mona graduate from Davenport with her Master's in Business Administration and Master's in Healthcare Administration 2012. Wow, you do a lot. Our other speaker is Hala Mallah, who's a health educator with the Access Substance Abuse Program, Community Coalition. She graduated from Wayne State with her master's in social work. She's experienced in supporting individuals, strengthening communities, and is focused on empowering others through education. We're honored to have them both with us, and they'll be presenting for 25 minutes. I'm just going to share my screen, and I will hand it over to both of them. Thank you. Inshallah. Okay, so I'm just going to minimize this slideshow mode.
Let's go back one slide.
Yeah.
Thank you.
All right, so you guys have the floor. Thank you.
Thank you. Assalamu alaikum. So the one thing that's not in my bio is my favorite title. I'm a mother of two boys. They just called me actually. So that's it's not in my bio, but it's my favorite title. And a lot of the work that I do is because of my family. I work at Access. Access is located in Dearborn, Michigan, and we are the largest nonprofit organization, Arab American nonprofit organization in the United States. We have over 100 programs, including employment and training, social services, immigration, community health and research, which is the department that I am the manager of. And we also have our National Take on Hate campaign, and we have our Arab American National Museum. It is the only museum that discusses Arab Americans coming to the United States. It's one of the most unique museums that relates to individuals coming from the Arab countries.
So you're gonna have to let people in the room, by the way.
Oh, I will? Okay. I have to work too? Okay.
I'm not technologically disabled.
There you go. So you can't do the removal, huh? Yeah, you can't, huh? That's fine. It's okay. I'll pay attention to it. Thank you. All right. Oh, okay. That's gonna keep happening. So this is not, I'm not sure. Let me see. Where are you guys looking at? Okay. Okay. Perfect. Thank you. I appreciate it. Okay. So sorry, I'm going to go back. So our research project is in collaboration with Wayne State University, which is also in near Dearborn. It's in the city of Detroit. And our individual who worked with us, her name is Cynthia Arfken, Dr. Cynthia Arfken, who I know is on here via Zoom today. So you'll hear from her a little bit later. We did this project, or we came together to do this project right before COVID-19. But then by the time the project came together and by the time we started doing our work, COVID-19 had did what it did, right? I mean, it took over the world. So it just, you'll learn more about some of the barriers that we had to deal with because of the pandemic. So the reasonings for our collaboration. The substance abuse, which I am learning about language with mental health and substance use. The word abuse is not something that we like to use anymore. It's substance use disorder. So even to be transparent, even for us, that'd be something I would change in my own presentation. It's a costly public health burden, which has killed over 67,000 individuals in the year of 2018. Now, the community that we are focused on is the Arab American community within Dearborn and Dearborn Heights, Michigan. And Arab Americans on the United States Census are considered white, and that creates a lot of limitations and disparities for Arab Americans. And so there is not a lot of research or conversations about substance use or mental health in the Arab American community. Substance use is also a disease which roots within social determinants of health, such as economic stress and discrimination. It's also impacted by trauma and mental health. And can you imagine the trauma that a lot of individuals from the MENA region face when they are, for example, war or fleeing to different countries for a better life for their families. More reasonings for our collaborations. There's a critical barrier to community involvement and research, and a lot of that comes from lack of education, lack of resources, and lack of understanding. Like you guys, if you've heard any other previous presentations during this conference, a lot of light bulbs went off for me, thinking about, what are some ways that we can focus on breaking those barriers within the Arab American community that we serve. Arab American communities are very reluctant to speak about substance use and mental health. It has been something that is very difficult because of a sense of pride, sense of failure among parents. So you will see that this is something that creates barriers within treatment, within prevention, within intervention. So when I was listening to the previous presenters about religion and how do you add that into someone's mental therapy sessions, or where's the line? So for example, we have a lot of times we get parents who will seek help from the local religious institutions, and the child, because of the force of the conversation, starts to push away from religion. So we are trying to work with our religious institutions to break that, because there has to be a reason for, there has to be like an idea of why is there like a gap? Why is there a gap between youth getting involved in or going into the mosque with a positive idea? There's a lot that can be said about that. There's a lot of things that have, I would say, taken to do with like cultural, due to age, due to parents who fear of losing their child to the American lifestyle and the American culture. So that is a different presentation, and there's a lot of information that I could provide at a different time on that. Stigma impacts policy investment in prevention and treatment. So what we found, because I have a unique program, just to give you guys a little bit of background of why this project came to life. So in Dearborn, I lead the substance use prevention program that is the first drug-free communities coalition to serve Arab Americans, and it's funded by the CDC. Prior to that, SAMHSA was our funder, and the first time I applied for funding, they said I didn't have enough data. So the idea that data became a barrier was something that I appreciate about working for Access, because we have partnerships with universities and we have our own research team. So we start to collect our own data, we focus on our own focus groups, we do our own surveys, and we add in the demographics of identifying as either from the MENA region or as Arab American. So that is very important for our work, to show what are some of the issues that we see that are happening within our community. The long-term goal is to reduce disparity and improve the prevention and the treatment of substance use and mental health among Arab Americans. So when we started doing our prevention work within the schools, within the mosques, within the city events, when we got businesses involved, we started to see stigma was really becoming a barrier for individuals to even want to talk about it. When we first held our events, the beginning about 5 years ago, when the coalition launched, we really couldn't get individuals to come and talk about anything. People would say, I don't want to come because our buildings are in the hub of the community. What if someone knows why I'm there? What if someone asks me, like, are you having a problem? Is your child having a problem? What is that going to look like? So when I first started doing my work, I was asked why I do this work and what made me come into this. Actually, my schooling is completely different. I should be working for a healthcare system. I refuse to. My faith and my ethics and morals would not allow it. I just wasn't comfortable with the way decisions were made on human beings. And so I decided to go to the nonprofit world. And when I decided to work in that field, I realized the stigma that was killing my local family and friends. And it was heartbreaking. I also lost my brother to substance use. He is everything to me for this work. Sorry. was asked yesterday, how do I separate it? I apologize. I usually can. But when it comes to really talking about stigma, I believe it killed him. Because that sense of belonging was taken from us. I have a very large family and we're very well known in the community that I come from. So when he felt like he didn't belong, it really took him. Obviously, I know the biology and I know how the brain works and I know what addiction is and I understand all of that. But I do believe it was a sense of shame and a sense of failure. So I hope to bring change among that and to destigmatize the idea that you are failing yourself or your child or your religion as a whole or God, because truly you're not. You're just in a stage where medical treatment is needed. And so that correlation is really important. Okay, so the collaboration leverages our federally funded coalition. Like I said, we are funded through the CDC. And then Dr. Arfken is from Wayne State University, and she has been essential to this work. She has really taught us the understanding of data collection, of understanding like what are the questions that we're asking in our surveys, why are we discussing certain components to our surveys and focus groups that we are holding. Our team is bilingual. We actually at Access speak over 19 languages, but Arabic is one of the top languages because there is a large Arab American population or Arab population. Our work has been successful to be submitted for an NIH grant submission. And this project was very successful, even though we were doing it on a social distancing, which, trust me, I've done focus groups and surveys in person, and I've done them over the phone. And that sense of, I can't hug the person answering my calls. I can't let them give me eye contact. I can't give them that idea of like, you're not alone. I can't let them know that it's okay. I can't say a lot of things because they couldn't see me and they were just listening to me. Versus when we used to hold them in person, we would separate the genders to give women more comfortable space to talk about decisions that they've made. And just the idea that we're very culturally sensitive in our work. Sometimes when we're presenting, we take every situation and think about, who's our audience? What are we going to talk about today? What level can I talk to them about stigma? I don't like people to feel like blamed for things. For example, when we're talking to parents, stigma takes the role of shame and failure and stress and my kid and I would never, and it can't be our community and we're religious and we're conservative and there's so many things that you guys know comes with it. And I'm like, we still have a mental health and substance use problem. And I also had to work through my own individual stigma of, am I the correct person? Do I have the right enough knowledge? Does my personal experience trump some of the knowledge that other individuals might have? There's just so much that I had to think about. But the best thing I can say is that I took it as a learning experience, and every single day, anything that I'm doing, anything that I'm observing is a learning experience for me. So I appreciate all you guys for everything that everybody's been presenting in the last 2 days. I'm going to hand it over to my wonderful, amazing colleague, Hala Mallah. Oh, I think that's still mine. I'm sorry. Before I hand it to her, I thought I was on point. I already talked about this. So we're strengthening our community research collaboration. We really want to create a platform for the Arab American community, not only on a community level, but on a national level, and to show the positives of community work, grassroots work when you're on the ground. And we also want to increase young Arab Americans to be involved in this work so that it can continue, and that one day we will be on the US Census, because I'm not white and I don't like to be considered white, because I don't get white privilege. So Thank you. And now I'm going to hand it over to Hala.
Thank you so much, Mona. And so again, just to go over what Mona was saying, the whole point of our work and the research work that we did was in order for us to inform our prevention work in the community. So again, a lot of the prevention work wasn't really applicable to Arab Americans, to Muslims, and then to non-Muslim Arab Americans as well. And so, for example, we do an evidence-based curriculum in the schools with a lot of our health education work. And although it's evidence-based and wonderful, it still has a lot of barriers for our community. So language barriers, cultural barriers, and a lot of the topics that we talk about, again, might be sensitive topics to our community. So we're trying to understand how to apply this kind of work in order to be more sensitive to the community and then to be most effective for the community. So this just goes over the outline of the research study that we did, and then I'll go into some more detail for each of the studies moving forward. So we had to begin somewhere, and that was with study one of this collaboration. And so what we did was to look at different scales that were already available that measured substance use disorder stigma. And so we didn't really have anything that was related to Arab Americans. And so we looked at different scales that measured substance use disorder stigma, and then made sure to adapt it to our community. And we made sure that the scales were from a collectivistic society. And so Arab community, the Arab society, the culture is more collectivistic. And so what the group thinks about you, what the group ideals are, really matters for the community. So as opposed to my own individual needs, I have to consider what my family, what my relatives, what those around me think of me, as opposed to the American culture, which is more individualistic. So we use that from collectivistic societies and then adapted the scale to our community. So changing some of the questions to say, in my community, most people think this, in my community, most people believe this. And I'll go into some more detail as well in the next slides. And so we made sure that the scales that we found were related and had the values of the society we're part of. And then we reviewed the scale by experts. They were made up of Arab Americans who were really knowledgeable about this information. And then this helped us go from 100 possible items to ask over to about 50. And then among our group, we discussed it, kind of said, what could we do without, what was kind of repetitive. And then that left us with 19 items for the first study. On to study two is when we began the interviews. We began with phone interviews, calling about 80 people from the community. They were Muslims and then also non-Muslims. And then we wanted to make sure that it was a balanced sample, so diversity within religion. We had Christians, and then we also had Muslims for this. Proficiency in English, so was English the first language, or was it Arabic or some other language? And then we also made sure to ask about the country of origin, immigration status, age, gender, and then if they had, what level of schooling had they completed. So we made sure to do that just to make sure everything was balanced. And then we also asked the participants, after asking the questions, what kind of questions did you think were repetitive? Or what kind of questions didn't make sense to you? And so with their feedback, we were then able to remove items that were needing to be reworded, stuff that was really going to contribute negatively to any internal reliability. So after that, we reduced the scale from 19 over to 11 items. And then we were going to be using that for study number 3. And then some of the questions that we had asked were, in my community, most people would think less of someone who has a substance use disorder. Or in my community, most people would be willing to marry someone who has a substance use disorder. And then we also asked questions about religion, if that was often recommended as something that would help prevent substance use disorders, and then if substance use disorders should be mentioned in schools, so about prevention work. And again, this was all meant to help us inform our further prevention work and practices. And then we did find that in this second study, that the Muslims did score higher, so they had more stigma compared to any Christian participants. And that really did support the validity of our scale that we were working towards. And then for study number 3, we then interviewed people again over the phone, but this time we wanted to ask for their permission to conduct this survey again in 2 more weeks. So with the first phase, or for the second study, we only interviewed the people once, got our results. The second study had a whole set of new participants, and then made sure we wanted to test the retest testability or reliability. And then we made sure that we were able to call them again in 2 weeks to administer the survey. And so with this, again, the goal was really helpful in helping us to find that valid scale that had high test, retest reliability, and that would help with our further work. And then for the fourth and the final study that we had, we shifted the use from phone calling over to a Qualtrics survey. And then we interviewed 100 Arab American parents and then 100 non-Arab American parents. So again, what was new here was that we wanted to make sure parents of students in the Dearborn Public School District were being interviewed. And then we compared that to the 100 non-Arab American parents. And then with this, we did find that, so again, since this work is to help us inform prevention work, especially in the schools, we did find that the Arab American participants did have higher stigma compared to the non-Arab American participants. And again, being parents of students in the school district. And then we did find that there was no difference in scores for people who had identified themselves, a family member or friend, as having a substance use disorder. So that was a new question we did ask during this study. And then we did find that one limitation was the sample was not balanced this time. And so that any Arab Americans were more likely to be male. And then anyone that was non-Arab would have been less likely to be an immigrant. So most of the immigrants that we had were Arab American, and then also most of the Arab Americans were male. So in order to fix that, we did linear regression, and then to predict the stigma score by providing mean scores as if the sample was balanced. And then with that, we did find that older age females, and then female Arab Americans in particular, did have higher stigma scores. So that was something new that we did find by doing that. So this work, just to go over the scientific progress that was brought on by this work, we were able to do something that, again, Mona had said was not being done a lot of the time, especially for our community, trying to adapt something that was applicable and then also helpful for the community. And then what we also did that was great was to add 3 different items that we felt were not reflected in any existing scales. So to ask questions about schooling and then also about religion. And then we also had the board of experts who were very knowledgeable on substance use, and then we're also Arab Americans themselves. And then a few more points to make towards the scientific progress of all this work is that the sample overall was balanced by gender, nativity, religion, and then also we did examine the internal reliability and then also factor analysis as well to reduce any items that may have been confusing or needed to be reworded. And then we did find that the final set did contain 11 items that had excellent internal reliability. And then also that there was, the demographic information did explain any of the less or more significant items. So for example, the issue with the balance that we had with the population, with the sample, we were able to find that this did support the validity of the scale and that we did have high test, retest reliability with this. And then with that, I'm going to hand it over to Mona to go over some more of the final points and how it applies to our community.
Thank you, Hala. So some of the efforts that we received in the short time of this work, we submitted an abstract to the Stigma of Addiction Summit, and we were accepted. We created a video that was translated into a 4-minute video, so that's something you can always go and check out. We were one of 6 that was accepted for this presentation. Some of the problems that occurred in the survey collection initially, obviously, will be hesitancy of community members to take the survey. So as you see, like community hesitancy is something that is very normal when it comes to these types of conversations. Now, us being within the hub of the community agency has been around for 50 years. There is a trust component that is there. And so we take it very, it's a responsibility of the agency to work with local universities that want to conduct surveys or hold any type of work within our community to make sure that the person that we are working for has good intentions, is going to bring outcomes into the community. And so we know that that helps take away the barrier a little bit because we're working with the local university. But again, there always is hesitancy that comes when you're speaking along. And obviously, as Hala showed you guys, we asked some deep questions about immigration, about, you know, where are you from? Are you documented, undocumented? So religion. So these are all questions that are not easy ones to ask. The other barrier that we also felt as I spoke earlier, is that we had to do this over the phone and social distance, and I'm not a fan of that. So I know that that was really a barrier for us, because we think that if we were able to hold focus groups in person, we could have gotten a different result in some of the questions that we asked. So our community findings, stigma towards substance use is very prevalent in the Arab American community. So we had done, I don't want to say evidence research on this prior to COVID, but we had done just some community conversations around stigma in the Arab American community prior to COVID. And when COVID hit in March of 2020, I think it was about maybe 2 weeks after, I had a conversation with my supervisor and said, we're in a lot of trouble. I don't know what we plan on doing, but we're going to run into so many barriers and so many issues, because we just sent people home to homes where domestic violence occurs, where child abuse occurs, where mental health is very valid, where students were going to school to get a sense of freedom, where students were socializing with other community members at school, because that's where, let's be very honest, in the Arab American community, your student going to school is something that you're, as a parent, you feel safe and you feel comfortable with them doing that. And you're okay with them staying at school and socializing. But then second that you tell them, let's go do things after school, that's a different conversation. And it becomes, why, and what are you going to go and do, and what do you need to go to the library to study, and all these comforts. Let's be honest, how many people got that from your parents? Why you want to go study at home? I'll make you food, I'll make you this, I'll do. Your parents will, I'm a parent, I will say anything to keep my kids by me. So we knew that kids were losing that sense of person-to-person conversation. So these were things that we knew were going to cause what we see today, which is increase of violence within the schools, increase of mental health and domestic violence during COVID. And somehow COVID trumped people's idea of going into treatment. People were too scared to get mental health treatment. People were too scared to go get prevention. People didn't even want to go see their primary care doctors, and we're now ending up in the emergency room for multiple other health reasons, because they're the fear of COVID. So that is another time and conversation, but stigma is ineffective in preventing the person from using substance use and does not help a person recover or seek treatment. Thank you guys so much. I did it in 25 minutes. That's my favorite thing, that I did it in 25 minutes. Thank you guys. Thank you.
Good job.
Thank you.
Assalamu alaikum. So I just want to reiterate to our guests, both online and in person, that we'll be entertaining questions in the discussion panel. So for our online attendees, if they could deposit their questions in the chat box. Our in-person attendees, if they could write down their questions on this card paper, we'll address them, inshallah, in the discussion. We're extremely honored to have two up-and-coming superstars in the field of Muslim mental health. We have Mona Midani and Taimur Kouser. I hope I'm not butchering the pronunciation. We'd like to welcome to the stage. So Mona Midani serves as a co-founder, board member, and manager of clinical operations of Maristan, a Muslim mental health nonprofit organization dedicated to providing culturally and religiously congruent trainings, clinical services, and educational programming. If you haven't checked out Maristan, you're missing out. Google them ASAP. She's currently a senior at Palo Alto University studying psychology and social action, where she also conducts independent research. Additionally, she holds a diploma in professional counseling and a certificate in family and youth support from Canada. Mona is also the lab manager of the Stanford Muslim Mental Health and Islamic Psychology Lab at Stanford University. Again, if you haven't looked at the Muslim Mental Health Lab, what are you doing? Okay, she's youth educator with the Rahma Foundation. Upon graduation, she aims to pursue a PhD in clinical psychology. Taimur Kouser. So Taimur Kouser, right? There you go. Okay, my bad. Sorry, apologies. Taimur Kouser graduated from Harvard with a joint bachelor's degree in neuroscience and philosophy, and from Duke University with a master's in bioethics and science policy. He's been a researcher at the Stanford Muslim Mental Health and Islamic Psychology Lab for nearly 2 years now, and is currently the team lead for the addiction team. So I'm just going to pull up their slides real quick. Come on, guys. Let's go. Let's give them a round of applause. Okay, 1 second. Why am I? Sorry about the delay, guys. I don't know why this is happening. Why can I not open it on Google?
It's PowerPoint.
Oh, okay.
Yes, we need to open it.
Yeah, I grew up yesterday, so yeah. All right, can you guys just like maximize the screen as possible? Sorry, my subscription's been canceled.
All right. All good. Assalamu alaikum, everyone. Thank you for taking the time to come and listen to our presentation today. Mona and I today, we're going to be talking about our narrative review of substance use and abuse research or addiction research in Muslim populations. Just before we get started, our team has no conflicts of interest to report. I just assumed it was.
No, it's not. Oh yeah, maybe it is. Okay. We have such a present team. Thank you. You're good.
All right. Our team has no conflicts of interest to report. And of course, I want to shout out the Muslim Mental Health Lab for all their support, Dr. Awad for her mentorship and her supervision, and everyone in the lab for their support and helping this work and helping all the other work throughout the previous years. Substance use and addiction. Substance use is a well-established behavior around the world, both in Western societies and non-Western societies. But of course, problematic or excessive use can lead to substance use disorders. Substance use disorders can be comorbid with other mental illnesses, with major depressive disorder, with bipolar disorder, with PTSD, and it can also cause a lot of other social harms, homelessness and economic burdens and emotional burdens, not only for the individual who's dealing with a substance use disorder, but also for families and communities more generally. And so at the end of the day, substance use and addiction are worth both understanding and getting a lay of the land for, as well as addressing in communities. When it comes to substance use within the context of Islam, I think the mainstream opinion is that substance use is prohibited in Islam, and that can become a difficult thing for addiction in Muslim communities and substance use in Muslim communities. Number one, it can lead to a lot of shame and guilt on the part of those who are using substances and on the part of those who are dealing with addictions. It can lead one to call their own faith into question, that perhaps dealing with this problem is something that takes me outside of the fold of Islam. That's something it questions me as a Muslim and my beliefs. It can also cause other community members, other family members to question the individual who's dealing with the problem, question their faith, call their faith into question, whether or not they're still part of the community. And of course, as the previous talk already mentioned, and as it's well known, perhaps most importantly, this prohibition of substance use within Islam can lead to a lot of stigma, and stigma is definitely a significant issue. We felt it was important, as young researchers and as researchers who are kind of very starting off, looking at addiction and substance use within Muslim communities, to find another lens through which to look at substance use and addiction. And so even with that, outside of the Islamic world and outside of Islam, addiction is talked about in a very moralized language oftentimes, and substance use is talked about in a very moralized language. We have other parts of our faith tradition, even if substance use is prohibited, that call on us to look at others who are dealing with this issue with mercy and with forgiveness. And so we have this hadith by him in whose hand is my soul. If you did not sin, Allah would replace you with people who would sin, and they would seek forgiveness from Allah, and He would forgive them. And so this reorienting the lens through which we approach this issue, whether it's research, whether it's community work, whether it's clinical work, through the lens of mercy and forgiveness, and almost a community mandate within Islam to actually address this issue, through a variety of means. Why do we care about addiction? Mona and I, but also everyone here, those people who care about Muslim mental health, people who are in the field. I think number one is that we have family, friends, or community members who use substances or who deal with addiction problems. And I don't think it would be a stretch maybe to say that everyone in this room, that this is true for. You don't have to go very far. You don't have to leave your city. I'm from Knoxville, Tennessee, where people don't necessarily think there are any Muslims. You can find the Muslim community there, and you still have these issues. And so this is something that affects all of us wherever we are, wherever we're Muslim. Number two is that in the lab, there's a lot of suicide work that's been happening to prevent suicide, to intervene, what happens in the case of a suicide. And a couple of years ago, when I first joined the lab and when we were talking to Muslim community leaders around the United States about the deaths by suicide that had happened in their community, this was, of course, the main topic of discussion, but they always mentioned that there's a problem with substance use and that there's a problem with addiction in the background. And so already between these first 2 points, we have a sense anecdotally that there's a set of anecdotal evidence that this is absolutely an issue within our community. Of course, anecdotal evidence narratives are important, but they can sometimes only get us so far. You have to be largely a part of a community, for example, to partake in, to understand the weight of stories. But maybe if you want to communicate the depth of a problem to communities outside of it, non-Muslim communities, or to others who may not be tapped in the same way, if you want to continue doing research, if you want to make sure that that perhaps the anecdotes that you have are not biased, that you actually know what's going on, then you need to have research. And so we wanted to understand how research can be used as a tool to address addiction and related stigma within our communities. And for this, we had some guiding questions. It starts off right here. How many Muslims struggle with substance use and addiction in North America and around the world, and why? So just a basic question about prevalence. Next is, do Muslims utilize mental health care to address addiction-related issues? So if there are people who are struggling with this, are they actually utilizing healthcare? And if so, how many and how effective are the resources? Then we have, what are the barriers that Muslims face in accessing religiously and culturally congruent care? And are there any community efforts providing care on this issue, and where, and how can those be replicated? And then we have, what is the relationship between religion and substance use / addiction for Muslims? And are religion and spirituality important at all? So later in the presentation, we'll talk about how we found that there's religious factors, but there's also non-religious factors that drive Muslim communities to substance use. And then finally, does the current literature on Muslims and addiction / substance use provide satisfactory answers to these questions? So this is kind of the questions we had in mind, and we wanted to go and see what actually existed. And for that reason, we chose to do a narrative review. Number one, because there's no specific question in mind. We wanted to have a very broad sense of just a lay of the land. What's known, what's not known. We wanted to specifically know what was being done in communities and how effective that's all been. We wanted to build a foundation of knowledge for us as researchers, but also maybe more generally around the topic of addiction and substance use in Muslim communities. And then we really wanted to identify the gaps in the current literature to see where more research can be done or more work can be done. Importantly, the review is not meant to be exhaustive or conclusive, and we understand that. There's, I'm sure, research that maybe we haven't seen, and that's largely a part of this conference as well. So we do want to say that, but this is a stepping stone for more research for us, but inshallah for others as well. Just quickly, search terms. These are some of the search terms we used, and these are some of the databases that we looked at. And in terms of the overall overview of the findings, we found about 124 papers, and we narrowed that down to 70 to actually be used in the paper. A lot of the papers talked about behavioral addictions, and so we didn't include that in this, and for other reasons we narrowed down. The majority of papers were on alcohol and then tobacco. There was maybe a handful on cannabis. There was a few on methadone, but that's all. So the majority on alcohol. And then the majority of them are from Muslim majority countries. And there's only a handful from, Western countries, from the United States, from Canada, from England, and others. The same way that those guiding questions, the thread, prevalence to how is the healthcare system being engaged, that's kind of how we categorized our findings, and we grouped the papers into those. So number one is prevalence. How many Muslims are, using different substances and where are they using it? Once you know that, maybe you want to know why they're using it and what's the perception around substance use. So that was our second grouping. Then what are the treatment options for those who are dealing with substance use disorders, and what's being done for prevention to kind of, loop back around. So these are the categories of findings, and I'll leave it to Mona to talk about those.
Thank you, Taimur. So as Taimur kind of started off with and initiated, the reason we did a narrative review was we really wanted to understand the lay of the land, and we really wanted this paper to set the stage for future research. Is this better? I'm a little short. Does that? Okay, it doesn't move. Okay. Okay, so we really wanted to get a lay for the land and understand what we could do for the next kind of research projects that we've been talking about in the lab, and how this paper can help inform those practices and, you know, further studies that we wanted to do. So when we looked at prevalence, what we found was Muslims do use less substances and compared to other religious groups in the papers that we found, but they were still using. So it wasn't a question of whether or not Muslims were engaging in substance use. Yes, they were using less, but we knew they were still using. And the primary focus, or sorry, like the primary substance that they were engaging with was alcohol and or tobacco. We had limited demographic details as we continued to kind of filter through these papers. So we couldn't really narrow down an age that was most impacted by substance use. We couldn't narrow down a gender. We couldn't narrow down any like socioeconomic status. We just knew they were using. Oh, that was great. I apologize. And then we knew that what we kind of continuously found was studies were done, but they were done on like very specific communities. So we had one in like London Borough on a Bangladeshi community, and we had one in like Toronto, Ontario, in this very small community. We had ones that were done in Beirut, ones that were done specifically on Syrian women. And so we kind of kept finding these little pockets of research that were done, but there was nothing that we can kind of adequately say, there's prevalence and we know it and we can identify it. And so what was missing was this detailed breakdown of demographics as we continue to navigate the papers. And there was really, again, Taimur mentioned this and it'll come up frequently, limited research on North American Muslims as we continue to like look through our papers. So as we kind of moved on through our paper, we decided, okay, the next step was to really look at reasons and attitudes. Why were people using, and what was the perception, not only of those who used, but also the community, religious figures, and their families. So what we did find was there was religious factors that kind of like impeded use. So interestingly enough, belief in God was a protective factor against substance use. But what in one of the studies that we looked at specifically with Syrian women, the number one reason they did not engage in substance use was actually for their physical health. Number two was belief in God. So it still wasn't like the kind of the primary, and other papers did identify it as kind of a primary reason to abstain from use. And then there was also kind of like varying opinions about substance use from the Islamic context. Like we looked at studies where even in Iran, for example, and they had disseminated a series of questions for imams in Iran. And when the answers came back, everybody had a different answer. And so you couldn't quite narrow down, even within a country, there were specifically Shia religious figures. Even within that subsect, you could not identify one common ground that all these religious leaders kind of held. And then, of course, non-religious factors existed where we saw family conflict. Trauma is a really big one. It came up in a lot of the papers. Of course, socioeconomic status and religious status was also a big one that we found. But what was missing was still this in-depth understanding across varying Muslim populations. And that's really going to be important for future research. We also didn't find, what was the difference in use among these kind of various demographic groups? Like, what were the differences? Did women use more than men? Did men use more than women? And as we continue to kind of like go through this paper, we're like, well, we don't really have answers to these questions yet. And then treatment. Treatment was a really big part of our paper. It's my personal favorite. So what we really appreciated throughout most of the papers that we found was there was a very robust discussion around Islamic-based principles and fundamentals being incorporated into care for individuals. And we saw this, there was a study where a lot of the studies actually, held treatment centers like at masajid, so that's what was used, and people felt safer. People felt more open to come and talk and deal with their struggles because it was a place of healing. It was a place of community. And so that was really kind of beautiful to see across some of our papers. We knew that community-based approaches rooted in Islam were successful in treatment, as well as, I mentioned this already, but religious spaces being used for treatment helped engage the community a little more. And in treatment, of course, stigma remains like a number one barrier to access and care with Muslim populations. Nobody wants to go and be identified as the individual struggling with addiction. And I know our previous panelist, Mona, you discussed language. We don't really use the term addict in the field because it's very identifying and it places this individual in a box. Instead, we'll say an individual who struggles with addiction, because we want to identify that you are a person in and of yourself. You are a Muslim, you are Arab, you are American, and the addiction is but a struggle. It does not define who you are. So what was missing when we looked at treatment was, again, treatment options for Muslims in North America. What are they? What are the best options? What do they look like? How do we, how do we find more religiously and kind of culturally congruent care for the individuals who want that, for people where God-centered people want God to be incorporated in their treatment? Well, is that an option for Muslims in North America right now? And we identified that as a gap because we just couldn't find papers on it. We also couldn't really identify like the effectiveness and like the utilization of these treatment methods, because again, just the lack of literature, and that's kind of like a theme, and we'll talk about those later, but just this like lack of literature that really discusses this very important topic. And we don't really have a method of incorporation of these religious treatments. So whereas yes, papers existed that had done treatment, had various like treatment methods, there wasn't a paper that actually told us as young researchers how to do this. Like if you want to replicate it, what does it look like? That didn't exist for us. So, definitely, again, something that we want to look forward to, inshallah, in future research. Prevention was the last area that our paper is kind of going to focus on, and stigma will come up again because it was one of the major studies that we looked at with prevention was a 90-minute psychoeducational seminar that was held in a mosque in Toronto. It was really neat because after the 90 minutes, most people said, I am now more motivated to go and help somebody in my life who's struggling with addiction. I now view individuals who struggle with addiction differently. And so we know psychoeducation is key. There's a lot of knowledge. We always kind of talk about this, and you hear a lot about it in like social media, the amount of fake news that exists out there. Well, you need empirically driven psychoeducational programming to support the ideologies and to kind of like reframe the way we view addiction. And Taimur talked about, well, within our Islamic, our deen, we understand that there's an amana to like support your community. There's an amana to be there and be present. And so whereas everyone, we focus on it being like prohibited and we have all these ideologies, we want to start shifting that narrative onto this other side. And prevention is going to be a very key factor in shifting those frames. And so when they focused on the community as a whole, instead of looking at these individual people like you're struggling and you're struggling, instead, this is like a public health issue. When you talked about the prevalence from a public health perspective, it was most efficient. In this 90-minute seminar, they recruited people from 9 different mosques in the Toronto area. So it wasn't just one mosque with a very specific, demographic. They went around, they recruited, and they brought people together and said, this is a problem. And what was really beautiful was because it was held at a masjid, a lot of people were actually more receptive to that information because, again, it came from this place of healing. That the people teaching, the moderators of the program were Muslim. And so people said that meant something to me because it was somebody who looked like me, who was talking to me, and I resonated with that versus, you're hearing it in a hospital, which is what one of the participants said. He said, it's not in a hospital, so you almost trust it, which tells us, and again, when you talked about distrust, and so, it was really beautiful. But even with that, what we're still missing is even in this study, there wasn't really an exact methodology about what specific aspects of the gene were incorporated or what is the best, method to incorporating those. And so that's really something that we want to explore further. And then just successful examples of prevention efforts in North American communities. We saw one, that doesn't, mashallah, that doesn't say a lot. We need more, and substance use is a huge issue. And when I talked about some stats, and we know just last year, for the first time in U.S. history, death by overdose exceeded 100,000. And so Mona, you had a number from 2018, so we're talking in just 3 years, we're seeing over, like 30,000 more people take their own life, and not take their own life, but through overdose. And so that's a really big number. And I really encourage people to start thinking about that, and have research like this and research like Mona and your team, that's going to be really important in doing that. So to kind of break down the themes of our paper, we looked at prevalence. And so we know there's a lack of substance use and abuse research on Muslim populations globally anyway, to start. When we looked at, just with regards to Muslim populations in general, research that was done explicitly on Muslim populations was limited, which meant Muslims could have happened to be living in the area that a study took place. They weren't the population of interest. And then when we look at North American Muslims, there's just not studies, but we do want to credit more recent publications as recent as 2021, which I believe that was the New York City. So they looked at the perceptions of imams in New York City towards individuals who struggled with addiction and addiction as a kind of concept. Islamic ethics. So I had mentioned that this came up a few times, and a lot of the researchers acknowledge more clarity is needed from the Islamic perspective on where exactly substance use lies and what is the kind of onus of a community or family to intervene and support. And one of the really nice things that we found in one of our papers was, as part of the treatment kind of goals, stage like 4, say, of treatment, they would invite the family members of the individual who was struggling with addiction to come and learn about how to kind of support this individual when they were released back into their home, because it's not the same. And integrative efforts, you know, to kind of like reintegrate into society is a really difficult thing if you've spent time in a rehab center or in a rehab facility. And then what they did from there was they had these individuals who were released from this program go and teach younger individuals about their experience, and in support of kind of in hopes, sorry, of maintaining this like education throughout the community and reducing these rates overall. And then prevention and treatment, you know, religious spaces came up a lot as an ideal place for treatment and healing. Religious figures, you know, came up a lot, the importance to have them understand and perceive addiction in this different kind of framework as well. With any research study, we did have our own limitations. So although it was very intentional for us to do a narrative review, it still wasn't exhaustive in content. So me and Taimur kind of acknowledged that there are papers out there that may not be included in our study today. And just revisiting the purpose for us was really like, how do we inform next practices? How do we inform future research? And how do we build off of this one paper? Our scope is quite broad, so we didn't specifically look at prevention, we didn't specifically look at prevalence, we didn't specifically look at treatment. And then, you know, we identify that papers should kind of separate Muslim majority countries from Muslim populations, because they're not the same thing. When we look at a Muslim majority country, we cannot generalize and say the experience of individuals who struggle with addiction in Iran, for example, that's not the same as individuals who are going to struggle with addiction here in the United States or in North America. So definitely future research should kind of identify that. So future directions for us, I think across the board, we need a better understanding of like the Muslim experience within North America on substance use and addiction. There definitely needs to be a, you know, more awareness and debate around the topic, kind of like in Islam, and just the overall community obligation. What is our role? We might not struggle, but as Taimur started off with, we probably all can identify somebody who has or who does ongoingly. And the integration of religion and psychoeducation and treatment, as well as utilizing religious spaces and helping our fellow community leaders and community members in how they can support individuals that they know as well, is going to be really important. So that's all we have for you. Thank you so much, everyone.
Yes, sleep. Thank you.
Thank you so much.
All right, thank you and Jazakallah khair to all of our presenters, as a matter of fact. So we'd like to move on to our discussion. I'm going to welcome, okay, first off, can we have the 4 speakers sit in the front row, please, if possible? Thank you.
Oh my gosh. Oh my God. We're still working. Always yeah.
So without further ado, we'd like to welcome our discussant for the next segment, Dr. Arfken, professor in the Department of Psychiatry and Behavioral Neurosciences at Wayne State in Detroit, Michigan. So she'll be leading the discussion for the next 20 minutes, where we'll entertain Q&A in addition to hearing her comments as well. So we'd like to welcome our discussant. Thank you.
Thank you. I'm just going to say a few comments because I want to leave most of the time for discussion. This was a fascinating section, and I'm very glad that it occurred. Looking at all the abstracts in the meeting, I wanted more about substance use because it clearly is a problem for the community, for public health in general. But I believe that part of this is the problem with stigma, that people are reluctant to look at it. People are reluctant to answer questions. So the comment was made, or the presentation, about the lack of information. One of the difficulties is asking people if they're Muslim. What is their religious affiliation? When I've done studies that have only included Muslims, I get very different answers than if I do a very large study and I just have religious affiliation. So people might not feel that they're representing their religion. They're only representing themselves when they're part of thousands of people answering it. So it's a big challenge. Another issue is asking about other people's experiences as opposed to your own. And when we do that, we find a greater problem and more information about what is going on. So I just want to bring those things up. And if there are solutions or people have ways to talk about the entire continuum of experimenting, continued use, problematic use, substance use disorder, treatment, and recovery, that would be great. And I look forward to everyone's questions.
So we have one question in the chat to Mona and Taimur. What databases did you use in your search? Any efforts to include gray literature? So studies from Muslim majority countries not typically indexed in US databases. I invite Taimur and Mona back up to answer this. Yeah, why don't you guys come back up? Yeah. Yeah.
I think there's a quick answer.
Go for it.
So thank you for the question. We primarily just use PubMed, and actually we did not have any efforts to include gray literature, but that's something that's I think an important consideration for future research.
And our limitation, we wanted to study specifically with majority countries versus non-Muslim majority countries and Muslim populations. That was something that was wanted to.
Yeah, absolutely.
There's also an issue of language, because some of these publications could be in different languages and therefore difficult to retrieve.
Absolutely. Thank you.
It's really hard.
So we have a question from an audience member. Two audiences member. You were first, yeah.
Sure. Okay, so first of all, for I just want to first make it clear that I really appreciate you sharing your personal experiences. That's really personal for us. Research that's going on. My question is, what future goals do you guys have in steps?
That's a good question.
So just for the online audience members, so the question was, what are the future goals for Mona and Hala in the domain that they're working in? So would you like to come up and kind of answer for the?
Okay.
Yeah, perfect.
So I appreciate your question. Thank you, and your comment. For the agency, this is one of our top priorities, if not our top priority. Looking into culturally sensitive treatment options for individuals, because a lot of times we get people who will go into treatment, come back and let the therapist let us know that they weren't comfortable there. We've had family members say, my son was being converted to a different religion, or my child was being taught a different religion, or they have to attend Bible study, or, whatever that could be one of the issues. But so for example, in the city that we live in, there's a lot of regulations to getting into treatment. It's not the best system. I'll say that nicely. Dr. Arfken, you can laugh because I'm being very nice about it. Unfortunately, if you have no health insurance, or if you have state-funded health insurance, you have to go through this rigorous system, and you kind of just get placed where there's a bed. Your gender, nothing matters. Nothing. It's just there's a bed, and that's where you're going. So that is a huge future take on that we're looking at as what is treatment, because right now we are a prevention team. We're an outpatient therapy team. I have a team that is working with the Dearborn and Dearborn Heights Police Department. So I created in conjunction with the Dearborn Police Chief, we put together a pilot program for a diversion team, so that I have 2 SUD advocates who go out with the police department, and they help individuals who are continuously getting put into jail because of mental health or drugs or substance use or suicide calls. So our goal through that is a long-term goal. My goal is to become a pilot program for other communities of color, working with law enforcement, because we know the stigma that comes with law enforcement for communities of color. There's good people in law enforcement. And I will tell you that this program came from the chief. We looked at other programs, and we looked at other teams that are doing this work in other states. But we came back and we added our component. So our team is bilingual. our resources are translated. I sit on all those boards that he mentioned because I work on a level with the state to get things translated to Arabic. There is not a lot of resources translated to Arabic. So for example, I recently with the University of Michigan, we have the Naloxone, which is a Narcan. It's given to an individual who overdoses. We had the information of what is Narcan, how do you use it, translate it to Arabic, to give to the parents and to give to the person who has someone in that is not ready for treatment and is still in that stage of, unfortunately, still not in the stage to be put into treatment. So we want to provide them with harm reduction kits. For prevention, like, what can I say? If my dreams come true, the state of Michigan will mandate prevention in the schools. Substance use and mental health need to be a class that is part of an everyday from the age of kindergarten and up at different levels. It does not need to be only us who come in and just are doing as much as we can because there's more people than there is us. So those are our future goals for the agency. My personal future goals is I want to go back to school now because I want to learn more. But thank you. I'll leave it to Hala.
And then just to add on to what Mona was saying, again, with the prevention work in the schools, a goal of mine would be, since I do a lot of work with youth, to make sure we're learning approaches that are relevant to the youth and that there's not a lot of pushback from the youth. If I'm talking about substance use, a lot of them are in shock and they don't want to learn about it. They don't want to hear about it. So I want them to learn more approaches, more ways to talk to them in a way that really sticks with them and leaves a positive impact instead of that resistance and, blocking it away. So hopefully with the schools, to reach more youth and to really help them benefit with that. Thank you for that question.
Thank you.
I just want to add that one of the barriers to doing prevention work in schools is the schools are afraid of stigma in the community. And they're afraid that they will get pushback from parents. So this study was trying to get more information about the stigma that might exist in the community and that ways that schools can address that stigma and therefore offer more prevention services.
Thank you. Thank you, Dr. Arfken. So we have another question from the audience. So the question is, there's a need for population level research, but there's also great value to looking at unique subgroups within Muslim American, unique layers of culture, race, etc. We'd like to hear the thoughts from our speakers and from our discussant on thoughts on balancing research on this. So broad research versus specific research. Did I do justice to that question? Yeah. So I'd like to hear, Dr. Arfken, if you have anything to say on that. Otherwise, we can ask the panelists as well.
Well, I would love to hear the panelists. I, of course, support a broad approach as well as specific. Because when you're doing broad, you can't get all the information you want, and that people are unique and there's different groups with different protective factors or risk factors.
I see. Thank you. Would any of you like to speak on that? All right. We welcome Mona back to the stage.
Okay, great question, mashallah. So there's definitely a benefit in studying very specific communities, kind of like a community within a community. And we touched on it in terms of you cannot generalize what you see in the Arab American community. You cannot say is going to be the same impact for, the Black and African American Muslim community in the United States, or just the Black and African American. It's not the same experience. One of the things that I'm going to credit Taimur to this, as we were kind of preparing, and we actually had brought up the census, and the census were all other or white. We're like, oh, okay, you go to healthcare and they're like, pick who you are. And you're like, well, I'm none of them. And they're like, yeah, just put white. And I'm like, but I don't look white. And when at your point, like, I don't get that white privilege. So no, I refuse to check white. One of the things that Taimur had mentioned as we were going through was in the United States, and if we just focus on the United States, but I'm originally Canadian and it's just as diverse in Canada, you can't really stop and say, oh, like you're Syrian and you're like Lebanese and you're from here. But what you can say is we're all Muslim. And so it was really, really important to make sure that there was research that engulfed everybody, almost like as a Muslim population, that you can stop and say, I might not be able to identify with research on like Arab Americans, but I definitely identify with research on Muslim Americans or like Muslim North Americans. And that was really important. So it's just as important to have that broad research, because when we look at, I think one of you said you didn't have enough data at one point. And when you look at that, you might not get enough data if you just continuously study these really small niche communities. But when you go and you're like, hey, like 4 million people in the United States identify as Muslim, these are the numbers, this is what we're struggling with, this is what we need, whether it's the educational system or whether we look at just more nonprofits that focus on this, more educational programming, more kind of like partnerships with Masajid. You need those numbers. You need those numbers. That's really what's going to put somebody like, huh, like this is a problem. And I think it's just really hard to do. And even in our paper, we had identified great papers, but small sample size, because you're looking at such a specific like population. And so we really did want a broader, we argue for a broader perspective too, because it's a good start. And from there, we can take that and implement on a smaller scale versus trying to work the other way around.
Just go up and like, if you don't mind, either of you want to like read out your question. You go ahead. I don't want to like, I don't even get lost in process. Sorry to put you on the spot.
That's okay. Yeah, no, thanks to all the speakers for really an amazing session. My question is a very practical one, which is for Mona and Taimur. Was there any evidence that these religious settings were integrated into the healthcare system in any sense at all? For example, was there any reimbursement given to these kinds of people to try to facilitate the kind of thing that would normally do in a healthcare facility, but has historically been ineffective? Or was there any other kind of information sharing to try to say, well, you can do this better than we can because of, you know, your population, the unique aspects of that, and we want to try to help facilitate that?
So thank you for the question. Mona, correct me if I'm wrong, but I don't think that there was any necessarily integration with the healthcare system, but that doesn't mean that it wasn't important to have these kinds of discussions, the support groups within religious spaces. So I think like Mona said in her presentation, hosting something at the mosque and bringing in the religious beliefs and bringing in that kind of environment, that was important, but I don't think it was like integrated into the healthcare system.
Yeah, no, that's correct. So one of the studies was donation based. So it was held at a masjid, and people who like benefited from the program kind of turned around and donated, or families who donated, and that's kind of what kept the program going. It was all voluntary work, so nobody who actually worked in the treatment facility was actually ever reimbursed. There was a study, I want to say in Cynthia, where they implemented it in a hospital though, and there was still, so it was government funded, but there wasn't the same response to it because again, it was at a hospital and people felt like you're viewing it more of a medical problem, and that didn't really sit well with a lot of people. Iran is probably what we found at the forefront of studying addiction in terms of like policy and just kind of like the implementation. They have one of the papers, they wrote like 4 papers. Congress 60 is a treatment facility in Iran. And, you know, one of the first studies they did there was actually a study on people who worked at Congress 60. And they found like majority of them had stopped smoking tobacco by the end of the study. And so, but not government funded or like kind of this like intersectionality between like religion and government and policy, nothing like that.
So then can I ask follow-up? How do you both, and maybe Mona, I'm sure you can speak to this also, like how do you think about sustainability of these kinds of programs at K 366? You know, like the grant is gonna go out, you're gonna publish your study, it's gonna be great, you're gonna give a podium at a conference, and then like the next day, you know, the funding is gonna fall off or the communication is gonna fall off and that sort of thing. So as you were reviewing this, Mona, as you're doing this work, like how do you think about sustainably creating these intersections in a way that is more than just like the dancing sense of principle person?
Mona, if it's okay, could you answer that on the mic? I don't want our online attendees to feel left out. If that's okay.
If you wanna.
Either Mona, both Monas preferably. Thank you.
It's like Mona squared.
There you go.
Okay, so it's mashallah, it's a very big question.
It is.
Could you just like summarize it real quick for our online attendees who may not have?
Sure. So basically, how do we make sure this is sustainable after our grant runs out, after our team is like, I don't want to volunteer anymore? and there's no money. Like, what do you do, and how do you make sure people are still getting the care that they need? I think one of the things that maybe both presentations alluded to is we really have to start conceptualizing addiction as a community issue, as a public health issue. The more studies that you do, that you can actually take and start implementing policy. And I'll tell you one of the things that we really wanted to do. And I think one of the importance is I actually presented at a local mosque back in October, and somebody from the crowd came up to me at the end of it and he said, I struggled with addiction for 10 years. He's a Muslim man. If you see him, you know he's a Muslim man. And he said he couldn't find a sponsor for 10 years. He couldn't find a Muslim sponsor. And every time he'd go to talk to somebody who wasn't Muslim, he's like, it's not the same, you know, and more, the research is limited. So we know that more research is needed to combat stigma. We know more psychoeducational program is going to be necessary. And I think before we can think of how to build a sustainable model, we really need to understand, do we know what we're dealing with? Like, how do you build something that you're kind of walking in blind? And that's not okay, because even like me and Taimur are very young researchers in the field of addiction, and like very early on kind of identifying. And I share one of the things that sparked this branch of research in the lab. Like, we'd always talked about it. Dr. Rania knew we were going to do this just based off of, you know, all the responses that we got when we did the suicide work. But I actually came across a video in Michigan of a doctor who was standing over, you know, this, I don't know, this trigger warning, but he was standing over the grave of somebody who just died of overdose. And he was like, please just go talk to your kids. He's like, just stop talking back, just sit down, listen, and engage in conversation with them. And I think that's really important, because if we want to build sustainability, we really need to understand, what are the youth struggling with? Because sustainability for youth doesn't mean sustainability for adults. We know in-treatment facilities are really expensive, and inshallah, as you kind of partner, I do think community partnerships are going to be really important in this. There's no shortage of Muslim-run organizations. We are not by any means a small population. We might be a minority, but among ourselves, we are not a small population. And we have to start believing that we can make that impact, but we also have to be ready to do that. We have to be ready to put in the work. And I think that that's the start to sustainability, is like, well, am I willing to see this through? Am I willing to complete this work? And if the answer is no, that's a different conversation. Maybe. So that's my answer. I don't know. I hope that addressed it to a certain extent.
Thank you.
You still need more answers to that? Okay. Sure. I hate following up on like amazing speakers. It's rough. Okay. Don't sell us short, I would say. Don't sell the Muslim community short. Sustainability is like, I think I say this all the time. I'm always talking to my team about, if I don't come back to work, if something happens, God forbid, what happens? Like, I can't feel responsible for this entire project and this program. If I leave, then what happens? So you got to think about your youth, right? So you're advocating for them, you're educating them, you're creating future leaders. Then you have to think about our current leaders. So politics plays a role. You know, getting things passed in Congress, being involved in advocacy, making sure you're on the front lines is very important to sustainability, because when things become aware, if you don't say anything, they don't know. I've said this multiple times. We vote in people because they might look like us or talk like us, or we know them, or someone told us to vote for them. Do your research, make sure you know who you're voting for, and make sure they are looking at what you want to see done in your community. As far as, so just to give you guys a little bit, I identify, I'm Muslim, but I work for a nonpartisan agency. So think about how I have to like separate that sometimes. I think that a lot, you know, she spoke a lot about Iran. Some of the work that is done in Iran that I really respect is they have opened their mosques to AA and NA. Okay. I've been doing this work for 6 years. I'm from Dearborn. I'm born and raised there. I go to the mosque and pray, and I give and I donate, but then I go there and I say, hey, can we start a recovery program here? And why are you here? What are you talking about? What do you mean? How are we going to let them in here? How are we going to let them use our space? What if something happens? This, that. And I go and I give them the research that I see in Muslim-led countries. So far, since we started advocating for that, we've had one. That's it. Like, and it's just so hard, because you were thinking like, you guys want us to prevent our youth from using substances. You guys want us to do all this work and bring people back to their faith and bring people closer to their faith, but then you're not comfortable with opening up your space. At Access, one of the things we did, like I told you before, is we do a lot of research, we do a lot of advocacy work. You want to make sure that at a state level, on a federal level, that you are being seen and aware. I advocate for more community organization work, more nonprofit work, more grassroots work. Don't be afraid to feel like you can make a difference, because you truly can. And like I vouch by the public health model. It's very important to look at this as a community. You know, when we want to have a wedding, we all show up. When we want to have a funeral, we all show up. When someone needs help because their child is struggling with addiction, that becomes an individual family problem. But we're all okay to start saying things about that. So those are things like in different perspectives. I really am an advocate for our youth group. I always tell Hala I can't talk to them, they drive me crazy, but I'm okay with giving them the tools to make them into our future, into this field. So those are a few things. I do want to say, you guys all know there's two sects to Islam. We cannot isolate each other. There's no reason for us to say, oh, this is a Sunni problem or this is a Shia problem. Politics is doing enough of that for us. When it comes to treatment and health, all of this, coming to these conferences, working together, partnering, is how you create sustainability. The same way that white Americans do, the same way African Americans do, the same Jewish Americans do, Muslims can do it too. We just have to learn to stop separating each other based on where you're from or what country you come from or what background you have. And that is something that I do see. We do need to stop doing that to each other, because health is just a human problem. And there's physical, emotional, mental health, and community health. That is a larger picture that we all have to look at it when we want to sustain our future with this work. Thank you.
Thank you. So we're running close to time, and I'd just like to thank all four of the panelists for delivering an extremely powerful message. And thank you, Dr. Cynthia Arfken, for her insightful comments. Dr. Arfken, do you have any closing remarks for us?
No, but I would love if anyone has further questions to email me, and then I will get back to you. So thank you for inviting me.
Thank you. We're extremely grateful for your time and for your insights, and it was lovely having you here. And we hope to see you again next year. Thank you. One final concluding remark, Access and the Muslim Mental Health Lab. So, you know, I've seen both of these organizations. They're both at the cutting edge. They're at the forefront. You guys want to be following these organizations now, because in 20 years time, you want to have bragging rights that you were following them like way before everyone else. So look them up, Google them. I think you guys are all on Instagram, all the major platforms. Muslim Mental Health Lab, right? Like it's like an epicenter of Islamic scholarship. You guys want to see what they're putting out there. Access, incredible work in the Midwest. I don't know, it's not the Midwest. Sort of East Midwest. Yeah. Both organizations are doing incredible work. You want to be following what they're doing. Hats off to you guys.
We don't have sun.
All right. I just want to say thank you to all of you for coming. I'm going to be ending this Zoom meeting now. Thank you for your time, for your patience, for your comments and questions, and I hope to see you again soon. Thank you, and Jazakallah khair.